So it is the 23rd. So we're going to talk today about the true glenohumeral joint. So the true shoulder, that's kind of the plan today. And this is for knees. Then we're going to talk about the manual muscle testing and the goniometry of both of them. We're going to talk briefly about it. And then tomorrow, after Therex class tomorrow, I'm going to do my best to demonstrate most of the manual muscle testing and goniometry for the shoulder complex and the true shoulder joint itself. And again, remember with the shoulder complex, which we covered Monday, there's no goniometry that you have to remember for that. Remember for that, there's just some manual muscle testing. So with the true shoulder joint, when we're talking about the true shoulder joint and when you're talking about patients with shoulder problems, typically we're referring to the humeral head in the glenoid fossa, right? And it's got a couple different movements. It's got flexion, it's got extension, right? And hyperextension according to the book, but that's just extension being fancy. We've got abduction and adduction. And one of the things it's kind of unique to think about, or not unique to think about, but with abduction, we're actually not going to measure that. What we're just going to do is we're just going to measure abduction going away from the body. And as long as the arm can return to the side of the body, we don't usually worry about measuring how much adduction a person has. As long as that arm can kind of come back and rest at the side of the body.
And can lateral and medial rotation be with the elbow like adducted to the body too? Yep,
that's what I was going to do right now. We're actually going to do circumduction, which is combination motion, right? We used to do that in elementary school all the time. Those stupid circles, big circles, little circles, big circles. Anyway, and then you have external and internal rotation, right? So lateral and medial rotation, that can be done here, but that can also be done here at the body itself, right? And that's mainly the way we're going to work a lot of our patients when we're doing exercises, because typically if they have external and internal rotation problems, they have abduction problems too. So putting them out here, they typically don't like. So a lot of our patients, we're going to be working kind of in this plane when we're doing the internal and external rotations. And then we have horizontal abduction, horizontal adduction, right? And that's going to be when we're talking about the pec flies or the delt flies in the gym, right? When you're either going back or coming forward with the machine. And then the other one we're going to add is scaption or scapular plane motion. And again, we talked briefly about that. But if this is flexion here and this is abduction out here, scaption's kind of out here between them. And scaption is one of the first times we're going to talk about it. Scaption is a functional plane. And what I mean by that is most of the motions we do with the shoulder are really more about scaption motions. You know, right? If I'm going to grab something off the top shelf in my cabinet, it's not like I go flexion, abduction, grab it. I just go up at an angle and grab it, right? And think about that when you're actually next time grabbing something off the top shelf, because you'll find that inherently a lot of times you don't grab stuff straight in the flexion field here. You don't put stuff up in the shelf in the straight flexion field. Oftentimes you do it out here kind of at a 45. And the reason why you kind of do that is that adds both anterior and middle delt to it, which gives you a little bit more strength, right? I don't know if anyone's ever gone to the gym and worked pure shoulder flexion by itself, but man, that anterior delt wears out pretty quick. It's not as beefy as that middle delt, and that middle delt's got supraspinatus up here to help it. Whereas anterior delt just has a little bit of biceps to help and the coracobrachialis. So most of the work when you're going into pure flexion is just your delt. So it's more of a scapular. The scapular is more of a functional plane out there. So we talked about all the motions and circumduction. Pretty rare that you're going to be doing circumduction with a patient. But I did once have to do a patient that was and I learned the term, I didn't know what the term was a POMI in the band. I guess those are the people that walk around with the pom-poms. I thought they were a cheerleader, but she quickly corrected me and told me she was a pommy, not a cheerleader. And I did not know this because I've never been in the band. I just bang drums. That's kind of what I'm more like Animal when it comes to music. But a lot of her techniques that she was doing as a pommy involved a lot of circumduction with the pom-poms. And so we spent a good bit of time. She actually tore her rotator cuff doing something. I don't even remember at this point. We spent a lot more time doing circumduction motions. And I was like, oh, and she's like, and if I ever become a fire eater, we're going to do a lot of that. I'm like, that's your future. You want to be a fire eater? Okay, sure. I guess, you know, she's got to have goals. It's my fan control. Oh, there it is. Sorry, just suddenly got really warm because I opened my mouth. I think I just let all the hot air out. So we got our scapula here. We covered all of these landmarks. The only thing we didn't cover last time I talked about it was those fossas. And those fossas are where we're going to hide a lot of our muscles, right? The supraspinatus fossa is going to hide our supraspinatus. The infraspinatus fossa is going to hide our infraspinatus. Subscap is going to hide our subscapularis. Good news is all of those fossas, you've got about the same name muscle hiding in there, which makes it easy for you guys. And let me ask this. Can we palpate the supraspinatus? What's anyone think? Can we palpate it?
No.
We can, it's just through the upper delt, right? In order to get there, we kind of have to move that upper delt out of the way and get down into that supraspinatus fossa. How about the infraspinatus? Can we find that in palpation? That one's an easy one to find. So then let's ask the fun one. Can we palpate the subscapularis?
No.
I think
Okay.
for an LMT you can maybe.
Yeah. Well, we're gonna palpate our subscapularis for sure, right? That's one of the techniques, because one of the things that we find is, guess where a lot of patients' trigger points are? On that subscapularis and the subscapular fossa. So now that brings the question, how do you think we are going to get to it? Because it sits under the scapula. How are we going to get to it? Anyone have an idea? Amanda says, yeah. Diana said, we can. How are we going to?
You could do that thing where you put your arm bent behind your back and it kind of flips the shoulder blade up.
It can, right? But the only problem with that is when you do that, all these kind of anterior muscles kind of tighten up a bit. So we're going to go in through the armpit. So we're going to have the arm kind of resting out here passively. A lot of times what I'll do when I'm palpating with the patient is I'll stand on their side while they're in prone or in supine. Doesn't really matter which way they go. I typically do prone because I pull up on the subscap. And then I have them put their arm around my waist so that their arm is kind of resting. I may have a gait belt that they're holding on to. And then literally, you're going to find the armpit. You're going to find that axillary border of the scapula. And you're going to go in and deep and under. And you're literally going to dig into that armpit. Let me see if I can get in under mine. And you're going to lift that scapula up. And right there is that subscapularis. You really have to kind of get those fingers in there and get on it. It usually is not very comfortable because you're kind of lifting the scapula up out of the way and kind of digging your fingers in under there. But what's really amazing is you get in there and you get your fingers kind of on that muscle, even just getting those fingers in on that muscle, which hasn't had really palpation ever, because who thinks about it? Once you get your fingers in on there, your fingers sink into that muscle and all of a sudden the muscle relaxes. And the patient's like, oh God, that hurts. Oh, wait, that feels really good. Because you've gone in there and you've kind of worked those trigger points that have built up in there for years. Most of us have trigger points in our subscap, just because it is what it is. We also usually have the infrascat as well, or infraspinatus. So we're going to get in there and kind of dig at that. Your trail guide has a really good instruction on how to get into that subscapular fossa under there. It just usually isn't very comfortable. But invariably, when we try this in lab, somebody is going to be really ticklish And the minute that we kind of start getting in there and getting into their armpit, they're going to be like, hee, 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 and giggle like a little schoolgirl, probably looking at John. So that happens when you're palpating. How do you stop somebody from giggling or getting ticklish? Does anyone know? I know we really didn't cover that in anatomy, but there is a method to it. Especially if you're like working their feet or behind the knee is another one, or right above the knee. Yeah, you got to distract them, right? And a lot of times what I'll do in order to distract them is I'm going to give a super firm grip on the humerus. So to the point where I'm not at the point I'm hurting them, but enough that they're definitely like, okay, that feels a little weird. Why are you squeezing my arm that much? And why I'm doing that is I'm actually activating the gate control theory. So if I squeeze that arm, they're not paying attention to me shoving my finger into their armpit to get to their subscap. It actually works pretty much anywhere. Like some of you guys, when we do the patellar mobs, are going to be giggling like schoolgirls too, because I don't know, for whatever reason, people have ticklish knees. And that's one where I kind of come up and I get a good firm grip on the quad. So I put my hand on the quad and I give kind of a squeeze and lift of the quad, and then I move the patella. And they're so focused on what I'm doing up here that they totally ignore the fact that I'm down here moving that. Thank you, Joe. So page 56. And also, I think it was you that commented on the Sunderland and stuff like that. I'm going to talk about that tomorrow. I did look at the book when I was in work. So we'll talk about that tomorrow when we're back in Therex. Hold on a second. Dr. O'Neill need the question answered real quick. All right. But yeah, so we can get in there and get on that. And honestly, I actually love getting in there and kind of loosening up that subscapularis, because it's a major area that kind of binds that scapula down. So if I can loosen that up a little bit, I may free up that scapula so that I can improve my rhythm back there. And that rhythm was what again? Of upward rotation to humeral movement. What was that rhythm again? What was that ratio? The force couple, right? But what was that ratio we talked about?
2 to 1.
2 to 1. There we go. Good. So we get our humerus, which, contrary to popular belief, this is not very funny. Anyway, she was on that. Yeah, she was on that. Right. So funny thing about the humerus is it does contain the funny bone. Right. I bet we never really thought too much about that. But is the funny bone really a bone?
No, it's a nerve.
Yeah. Right. Cha for sure. Right. The funny bone really is our ulnar nerve. Right back here in the posterior area where it kind of comes through and passes through right about there. Right. Funny bone really is just the ulnar nerve. All right, so we got our head, right? We have our anatomical neck, and then we also have our surgical neck. What do you think and I mentioned this before at the hip, but what's the difference between an anatomical neck and a surgical neck? Why do we have 2 different necks? Anyone have an idea?
Is it for like if they have to do like a full surgery or half?
Yeah, well, part of it is if I'm going to do a full replacement, that surgical neck's where I'm cutting off the whole top of the humerus, right? Or that will be where that implant is going to go to if I only have to replace kind of this part of the humerus, because that's kind of the structural strength point of that humeral, the whole top part of the humerus. So we got our greater tubercle and our lesser tubercle. And I saw a great book the other day that actually called them, are you ready for this? They said the greater trochanter and the lesser trochanter of the humerus. I'm like, no, stop renaming stuff. No, they're tubercles to us. How can you palpate your tubercles? Does anyone remember how I showed some of you guys to palpate them? This is an easy way to palpate them. So what I want you to do is take one of your hands put it up where you would expect your tubercles to be about, I'm going to do the hand that I can actually feel with. That's probably smart of me. Put it where you expect your tubercles to be, and I take my 3 fingers and I lay them over that kind of aspect. And then what I want you to do is internally and externally rotate your humerus. Bump, 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 bump. Do you feel those bumps now? That's how you find them. As you look and you kind of find those little bumps as you're moving through it. Does anyone, you guys kind of feel it a little bit there? Or is everyone asleep? I mean, it's okay if you're asleep, but okay, good. Which one is more lateral, the greater or the lesser? Okay, greater. So Truman's saying to have a little trouble. If you're having a little trouble, palpate a little deeper. So get a little bit more aggressive on your palpation. And it may just because you're so swole, Truman, that you just can't feel them. See, I was going right there, right? So greater is a little bit more lateral, right? And the sad part, what I find is, for whatever reason, people have a harder time finding that greater tubercle than the lesser tubercle. I don't know why. It seems like when you externally rotate, okay, there's my lesser tubercle, but when you internally rotate, you have a trouble finding that greater. Because it almost feels, and I hear this a lot, it feels like that lesser tubercle is bigger. Why is it harder, do you think, to find that greater tubercle on the outside?
Because of the end of your clavicle, maybe?
A little bit of the end of the clavicle, right? And also, you've got that delt lane there, like, yeah, the delt, right? The delt's kind of in the way. So you kind of do have to kind of get in there and get under it and get on it in order to find them. In between that greater and lesser tubercle, we have that bicipital groove, or what's the other term for that groove?
Intertubercular.
Yeah, intertubercular groove, right? Otherwise known as just called the bicipital because it makes it easier, right? So the bicipital groove or the intertubercular groove. You also kind of come down and we'll find that deltoid tuberosity. That one's kind of hard to find on your arm. But if you think of the way the deltoid works, and it kind of forms a pyramid or a diamond-shaped muscle. If you can come down to where you think your deltoid tuberosity would be and start feeling around and find the part where it's kind of painful. If you find the part where it kind of hurts, and that doesn't make sense on that arm, I can find it over here. Find the part that kind of hurts. I'm coming down, and I get to a point where when I go back and forth over it, it kind of hurts. That's probably your deltoid tuberosity. It's a little lower than most people think, because the delt's actually bigger than most people think. And why does it hurt? Well, that's the attachment site of the delt, and you're irritating the deltoid. So that's why it's a little painful to find. You also have this thing in the middle of it called the spiral groove for the radial nerve. Can you guess what passes there? Gee, I wonder. The radial nerve, yeah, right? And you do have the ridges, right? So those bicipital ridges that are kind of on either side of that groove that exist, they're not as important. That's kind of the slopes going in. But if those ridges become kind of malacia, where they get softened, they can kind of tear at that bicipital tendon, which is one of the reasons we'll get bicipital tenosynovitis. Then we get our good old joint capsule here, right? Which we talked a little bit with the other day when we talked about the shoulder, right? And again, the joint capsule is what's holding everything in place. And we're going to rehash capsular patterns here towards the end, just because I had a request to cover that again, to talk about why something would be a capsular pattern. But in the case of what a capsular pattern is saying is, here's our capsule. We have all these ligaments holding the shoulder head in. But on top of that, we've also, here's our supraspinatus, here's our delts, here's our biceps, right? Here comes all of our rotator cuff muscles in various places. So when I talk about a capsular pattern, I'm actually coming in and I'm going to erase all those muscles, because when I talk about a capsular pattern, I don't care about the muscles. What causes the capsular pattern is all of these ligaments being tight. So these ligaments bind down. So that is what triggers a capsular pattern. And that's why when we mobilize, right, when we do a joint mobilization, we're not really worried. I mean, do we get a little bit of stretch in the biceps? Sure, we get a little stretch in the biceps when we mobilize stuff, or we might get a little bit of stretch on supraspinatus. But what we're really kind of stretching out is these ligaments. So if I'm doing something like a anterior to posterior mobilization of the humeral head, what I'm going to stretch out here is these anterior ligaments of the capsule in order to kind of loosen it up. If I'm doing a inferior mobilization, so I'm pushing that shoulder down, so I'm doing superior to inferior, I'm going to be stretching out this coracohumeral ligament pretty heavy, as well as a little bit of this ligament here and these two little ligaments here and those ligaments in the acromion process, because they're going to get a little stretched out. Even if I'm just immobilizing that humeral head, I'm also going to be mobilizing most of the stuff around it as well. Not going to really mobilize that labrum. That labrum is just the way it is. It's just there, right? Although when I do mobilize the shoulder, especially when I superiorly mobilize the shoulder, so an inferior to superior mobilization, I can help get that humeral head back into the labrum where it should sit.
So, Mr. McKeever, when we're doing mobilizations for the joint capsule, it's mostly prom, correct?
It is PROM, yeah. They're not going to do anything to help us. Yep. We're going to get in there and just kind of bang off those bones and muscles, or bones and ligaments, and they just have to relax. And if they don't relax and they tighten up, it actually makes our job harder. Because when they tighten up, we can't mobilize those bones. All right, so then we're going to look at the muscles. We got our anterior delt, our middle delt, and our post delt. Anterior delt is our primary what? What does anterior delt primarily do?
Flex.
Yep. Shoulder flexion, good. What does middle delt primarily do?
Abduct.
Yep, shoulder abduction. And then our posterior delt is our primary shoulder what? Extender. Good. Right? You wouldn't think about that because when we talk deltoid, we think, well, it's just one kind of muscle here. But all three of those parts do a very distinct job at the shoulder. Now, does that mean that my latissimus dorsi doesn't do extension? No, absolutely. Lats do a little bit of extension. Does that mean that my bicep doesn't help with shoulder flexion? Sure, it helps with shoulder flexion. But these three muscles are our primary shoulder movers. So when we get a patient that we're doing rehab on the shoulder, we've got to strengthen that delt, right? And a lot of times when we strengthen that delt, one of the big exercises we do are called YTIs. Has anyone heard that before or seen that before?
Yeah, I do them before every shoulder workout usually.
Good, that you good, because you're firing up that delt and kind of tightening that humeral head in there. So a YTI is exactly like it sounds. You're gonna have them doing a Y, right? T, which helps with that, and then I's. And I tend to add with my T's, I tend to have them also come out and form a T here this way going into pure abduction. So I may have them do horizontal abduction T's to get retraction going on, but I also have them come out and do abduction T's to get that middle delt fire. And we miss that a lot. And then our eyes are going to come back doing extension. And like Joe said, that's a really good exercise to fire up that shoulder complex, to get it kind of working. Because even when I'm doing, I'm not familiar with W's, but I don't think I've heard of that one.
Let me put on my camera.
Yeah.
You go like that and then like that.
Oh, okay.
Focus on that and then you.
So the external rotation motions. Yep. Okay. I just didn't hear them. I've never heard them referred to as W's. So that's news to me. YMCA. If you do some YMCA, sure, why not? Right? That's the extent of my dancing. You're not going to get any more. But YTIs are a good exercise because even if I'm doing my Ys and I'm coming from straight bed down here, up here, am I getting some rotation going on in the shoulder?
Yes.
Yeah, right. So I'm even working some of my rotator there. If I'm coming here and going out, I'm getting some of my rotators firing. And again, if I do abduction, getting some of my rotators. And if I get extension where I'm coming straight down, I'm getting my rotators firing. So it kind of wakes up, those YTIs really do wake up the whole shoulder. And it gets it ready, especially if you're a person that's going to then work the shoulder kind of heavy, right? And we can do them just in the air. We can do them with dumbbells. We can do them with cuff weights. We can grab good old resistance bands and work them with resistance bands. We got our pec major, and that includes both our clavicular and our sternal portion. I wanted to talk briefly about this because this is something we forget about when we stretch out pec. What's our major pec stretch?
Is it the wall stretch?
Okay. I had not heard it called the wall stretch, but I think you're going to the doorway. There we go, the door stretch. I think the wall stretch is just a corner stretch, I think is what you're thinking of. But the doorway stretch is the big one I do with my patients. So what a doorway stretch is you have them come up to the doorway, they put their arms on either side of the doorway, and they take a step in. And that brings their arms back behind their body, and that opens up that pec, right? But what we forget about doing that is a lot of times we do it kind of here, which does get the clavicular portion and does get the sternal portion kind of in a combo. But most of the time when I do my patients with the pec stretch, I do the three-way door stretch. Has anyone seen patients do a three-way door stretch before?
Is that at different levels or different heights?
Yep, exactly. Yeah. So with the three-way door stretch, what I do is I do what's called 135, 90, and 45s. So I'll bring them up to about 135 of shoulder motion, and then I'll have them stretch. And if I'm way up there, I'm stretching out those sternal fibers. And then I bring them down to 90, and I get a general pec stretch. And then I bring them down here to about 45, and I have them do it. And now I'm stretching out those clavicular fibers. So usually, and again, these are general angles. These are not exact, right? 135, 90, and 45. Now, in order to do the three-way pec stretch or the three-way door stretch, they have to have functional motion of the shoulder, right? Because if I've only got 35 degrees shoulder flexion, I take what I got and stretch where I'm at. If I've only got 90, I take what I've got. But if I've got somebody that's got some functional motion of that shoulder, then I like to do high, middle, and low door stretches because that opens up that whole pec. If the patient can't do a door stretch, one of the other things I like to do for them is I have them lay down on a gym bench, or I can do it on a table if they don't have a gym bench in the clinic, but they're going to lay there and I give them about a 3-pound dumbbell and I just have them lay on their back and let those dumbbells pull their chest way out. And so I just let them rest, let them pull them all the way back and just have them rest there for a long and slow and hold stretch. If you're feeling froggy, you can give them heavier weights. Like, I don't think a 3-pound weight's really going to stretch out Joe too much. He's probably going to need a 7 to a 10-pound dumbbell in each hand to get a good open stretch going on there. You can also do the doorway stretch or the chair stretch or the table stretch, whatever you want to call it, by just putting a foam roller down their back. So I can put a foam roller behind me on my chair and just go backwards. And that foam roller will help me kind of canoe my middle of my back and open up that chest again. Why is it important to stretch out that pec? Well, because we all sit like this, right? And that pec is always super tight. And again, if we get this pec tight, right? All this pec, all these anterior muscles are tight. Anterior deltoid's a little tight. What happens to all the muscles in the back?
They get stretched out?
Yeah, they get stretched out, which can lead to stretch weakness, right? So if I've got somebody that I know, I'll answer your question in a second there, Oscar, that I know is kind of a texture that spends a lot of time, or a gamer, they're spending a lot of time here, right? I've got to stretch out my upper chest and I've got to strengthen my back. I've got to get them doing a lot of retraction activities to strengthen that upper back. And half foam, yeah, half foam is kind of where I start them, Oscar, with the half foam roller, and then I can progress them to where they've got the full foam roller, or even laying fully on the foam roller, doing kind of retraction of the scapula to stretch out that pec. Pull up towel. I'm not sure what pull up towel means. Here, I pulled up a towel. Oh, you know, this is just a.
Sorry, no, I just meant like if you pull up the towel like from your back, like.
You mean down the back like this?
Yeah, like that. Would
Yep,
that
we're gonna talk about that for internal and external rotation in just a second.
Oh, okay.
Yep,
So what's that called? I'm sorry, just
that's
so
this is the towel stretch, is what it's called, right?
Oh, okay.
But this is for internal and external rotation. We're actually going to talk about that. Yep, going to talk about that in just a second. You're just a little ahead of me. And Anthony's like, I'm doing that right now. So then we've got here our lats. Our lats help out with extension, right? We got our teres major, which we forget about quite frequently. Does a little bit of kind of horizontal abduction, does a little bit of rotation, but it's not one of our primary rotators. Our primary rotators are our sits muscles, or otherwise known as supraspinatus, infraspinatus, teres minor, and subscapularis. Those are our primary rotators. And when you look at this picture down here, that shows how all of those muscles sit. So this is my humeral head, and this is kind of looking out from the humeral head, looking out. So if you could go into my glenoid fossa and look out, it kind of looks at where they attach. So here's my bicipital groove. That's where my bicep's going to go over. I have my subscapularis here. My supraspinatus sits on the other side of it. I have my infraspinatus sitting there, and then my teres minor sitting there. That is a very, very, very tight window to where those muscles all sit, meaning there's not a lot of space there. So you screw one of those up, and a lot of times it's not like you're just going to tear supraspinatus. A lot of times you're going to tear supraspinatus and infraspinatus, or teres minor and infraspinatus. Subscaps kind of sits out there on its own, so that may be one you tear on its own. Which one of those is our primary internal rotator?
Subscapularis.
Good, subscap, right? That's our primary internal rotator, right? So that's our one that gets really tight. And again, when it sits under all those muscles and under that scapula, you can understand why that would get really tight. So that leads to exactly where Diana was talking about. How do we stretch those out quite frequently? And that's called the towel stretch. Or I can use a belt. I prefer using a belt over a towel. And all I'm going to do is I'm going to drop this thing down. And I'm going to have one hand up top here by my head and one hand down bottom here by my back. Now, if I pull up on this, am I working internal or external rotation? If I'm pulling up with my right hand and pulling my left hand up my back. That feels really good. I can sit here for a while.
Internal?
Yeah, I'm doing internal. Good. I couldn't see John's thing there because I was stretching out my subscapularis there, right? So I'm doing internal. I can change that up now. And instead of pulling up, I can pull down. And when I pull down, now I'm working my right arm's external rotation. So I can hit them same. Let me go grab a towel just so that I can show you how we do it in the clinic regularly. I didn't think to grab a towel earlier. I do the same thing with the towel. Throw it over my shoulder. I can pull up. I can even pull it this way if I can't do that much external rotation, and just pull it kind of forward. And I can work that internal rotation, and then I can do the opposite and work external rotation. Now, there's one thing a lot of clinicians forget doing this. If I only need to work internal and external of one shoulder, when I get through with all my internal rotations, I have to flip. So say I'm supposed to stretch my internal rotation 3 times 15 seconds. So here, stretch 1, 2, 3, 4, 5, 6, 15, good. 15 seconds, good. 15 seconds, good. If I need to work this left arm for external rotation, I have to flip it. And now I can pull down and work my external rotation. 15 seconds, good. 15 seconds, good. 15 seconds, good. And that allows me to work both directions. Does that make sense? We forget that a lot. We're like, oh, well, I'll just have them pull down. Well, no, now you're working the other arm. It's a common mistake. Just don't let yourself make that mistake. And then your clinician can laugh at you and say, is that really external rotation? You're like, oh, son of a gun, Mr. McKeever warned me. So just don't kind of make the same mistake. I made that mistake in my outpatient and they picked on me. So trying to avoid you guys getting picked on. One interesting thing also to think about here, though, is with the lats, if my lats are tight, could that lead to back pain?
Yes.
Oh, absolutely. Right? Because right down here, here comes my good old TRA, or my transversus abdominis, that attaches back here to this posterior thoracodorsal fascia, thoracolumbar dorsal fascia, the fascia that's back here, kind of that goes between them. I have my erector spinae back here laying over it. But if this really gets tight, that's also going to pull up on my lower spine. And that can lead to low back pain. Right? So we may have to stretch out those lats a little bit in order to kind of loosen up that low back. So if we know that the lats help with extension of the shoulder, what motion are you going to move me into to stretch them?
Flexion and trunk lateral rotation.
Yeah, you can do, right. So start with just flexion, right? Start there to start with, so we can stretch out both the posterior delt and the lat, right? And then if you really want to get the lat, you get some kind of trunk lateral rotation going along with it to really get that stretched out, for sure. Because somebody asked me a question about that the other day is, well, how am I going to remember which way to stretch a muscle and which way to strengthen a muscle? Well, to strengthen it, you go in the direction it's supposed to go. So if I want to strengthen the lats, I need to go into shoulder extension, right? Or if I want to strengthen my posterior delt, I go into shoulder extension. If I want to stretch them, you just go the opposite direction. Does that make sense? You just go towards the other way. Yes, Brooke.
I was going to say, so whatever the muscle does, you kind of do just to strengthen.
Yeah, so yeah, whatever the muscle does. So I'm going to use the bicep as a really good example here. What is the bicep's responsibilities? Its primary job is what?
Stabilize?
The biceps. No, primary job, I'm just talking in general. Don't worry about the shoulder itself, but your primary job is elbow flexion. Good. What else does it do?
Shoulder flexion.
Shoulder flexion, good. And then it has one other job.
Pronation?
It's
Supination. It does supination. It pulls you from pronation to supination. So if I'm strengthening the bicep, all of those motions are going to work the bicep, right? If I actually wanted to do all of that, that would put it in a maximal active insufficiency, maximum on shoulder, right? So I would do a little bit of, I do full elbow flexion, shoulder flexion, and supination. That's got my bicep as short as it can be. If I wanted to stretch my bicep, I'm just going to reverse my motion. So I'm going to pronate the forearm. I'm going to extend the shoulder, and then I'm going to extend the elbow. In that position, I've got my bicep on what? What would my bicep be in at that point? What's it called when I can't stretch any further?
Passive insufficiency.
Good, passive insufficiency, right? So when you think about it, when we're strengthening, we're moving towards active insufficiency. When we're stretching, we're going into passive insufficiency. Did I just blow anybody's mind yet? That, oh, clicked, good. Right, now, does that mean if I just extend the elbow, I don't stretch the bicep? Sure. Right, if you extend the elbow, sure, you're stretching the bicep. To get the maximum stretch on that bicep, though, I've got to get the reverse of all its motions. And the bicep does two joints, right? One joint muscles are a lot easier, right? So in the case of middle deltoid does shoulder abduction. If I really wanted to stretch out my middle deltoid, what would I have to do? That's because that's all it does is abduction. I'd have to come into adduction, right? And I kind of have to cross the body here because you really can't, I mean, it's not like I can't go here. I have to kind of cross in the front and stretch across. And if you do that right now, if you come across your body like that and pull at kind of the elbow level, you should feel that middle deltoid and a little bit of supraspinatus stretch out. Did that help click for some people a little bit? I know it clicked for Diana. Did that hit anyone else? That hit for anyone else?
Yes.
Okay.
Yes.
Cool. So when we are working in the clinic, and you guys are out in the clinic, and it's your first time out there, and you're freaking out because, oh my God, they just asked me to strengthen the deltoid, and I don't know they asked me to strengthen the middle deltoid, and I don't know any exercises to strengthen the middle deltoid. Well, we're going to do a manual muscle test for middle deltoid. Guess what? Turn that into an exercise. Your manual muscle tests are some of your first exercises you're going to do. Right? So turn that into an exercise. And then I'm like, then your instructor's like, well, I need you to stretch out, I don't know, you need to stretch out the coracobrachialis. I don't know why you'd be stretching that, but whatever. You're stretching out the coracobrachialis. Well, I know that my coracobrachialis goes from about my middle clavicle to my bicep region, so right in that humerus. Well, if I need to stretch it, if I put my arm way back here, I'm kind of stretching out my coracobrachialis. You just go the opposite of whatever it does. Not that you're ever going to really stretch the coracobrachialis. I'm just saying you're not. But you just do the opposite motion, right? So if my internal rotators are tight, what motion am I going to do to stretch them? External rotation. Good, right? And here's a neat thing to think about. My nose is driving me nuts. Pollen is just driving me nuts today. Here's a neat thing to think about. When I am strengthening into external rotation, if I'm strengthening my external rotators, making them do work, because they are firing, my internal rotators are relaxing. What was that called again? I mentioned that yesterday. When one fires, the other relaxes.
Reciprocal inhibition.
Reciprocal inhibition, good, right? So there's actually tricks I can do where I can make those external rotators fire and fire them off to relax my internal rotators and stretch them. We did that a little bit when we did that PNF kind of stretching. Little tricks, right? But then we learned on the commercial, unfortunately, that tricks are for kids. So there's our supraspinatus sitting up there in our supraspinatus fossa, right? There's our subscap. There's our infraspinatus, and the teres minor and the infraspinatus lay kind of right over each other. So you're not actually going to truly get, when you work, it's not like you're actually ever going to just work teres minor and ever just work infraspinatus. They work in conjunction with each other as a force couple to move that humeral head. So there's looking at that again from the inside out. That's the force couple, which creates my rotation of my humeral head or my shoulder rotation. So what's kind of important to know? Well, again, we do have some force couples going on in general motion, right? If I am going up into either abduction or flexion, my rotator cuff is going to work in conjunction with those muscles to keep my humeral head in that glenoid fossa so that it stays there and doesn't just fall out. Because here's the deal. If there was no rotator cuff grabbing onto that humeral head, and I went out here into shoulder abduction, what would happen is that humeral head would just fall out the bottom. It would be going along convex concave rule. Exactly. That comes into play, right? It's going to help that if I'm moving superiorly, I've got a vex surface moving on a cave surface, those muscles, those rotator cuff are going to help glide me inferiorly in order to keep me in that cave, because vex go opposite, right? If you're vexing, you're an opposite. Does that make sense? That's what that force, so what this is showing is that if you don't have it, everything's going to fall out. So you need to have those force couples working to keep that humeral head in the socket. And all those muscles kind of work in conjunction. Meanwhile, the deltoid is doing most of the work, right? The delt's the one that's primarily moving a lot of this humeral head. But all these other muscles are helping to combine to keep that humeral head nice and close into that socket and gliding. Actually kind of cool the way we're designed. Maybe it's just me, but I think some of the stuff we do is kind of amazing that we have all these muscles working in conjunction. We don't have to think about it. We may think about moving our arm up like this, but we don't think about that humeral head rotating. That's all intrinsic. Pathology, some of the stuff that can happen. We can have an AC separation, either a grades 1, 2, or 3. And it's just like anything else. A grade 1 is just a little bit of a tear. Grade 2, a little bit worse. And then a grade 3, we get almost a full separation, which we talked about those yesterday. We can end up with the clavicular fracture. That's where that clavicle will snap. We can have humeral fracture. I have a couple of pictures of these coming up in the next slide. So in a clavicle fracture, we can have a humeral fracture. We can have a shoulder dislocation, where the shoulder kind of slips downward or subluxes and then eventually dislocates. You can end up with impingement syndrome, where because we have all these bones and tendons up here, stuff gets pinched, right? Impinge means I pinch. It's up on Blackboard already, John. I'm sorry, I posted it. It was literally, you guys popped in and I was finishing it. So it should be up on Blackboard for you. Yep. The old one was up for a while, but this just got posted. So I modified it a little bit. Can end up with rotator cuff tears, or we have this LHB tear in injuries. What's an LHB? So I'm sure somebody in here is going, I have no idea what that is, and I don't want to ask it. Long head. Biceps, good. Yeah, so the long head of the biceps. That is the one that gets injured more frequently than the short head. The long head, for whatever reason, likes to get injured more. And I think it's because of the length and the tension on the long head. But, you know, I don't know for 100% sure. Again, I'm not a shoulder specialist. I shoulder knew that. So here we have some great pictures. Yeah, I see your problem right there. Does anyone know who this is a picture of, by the way? Actually, this is a famous athlete's picture here.
Is it Tony Romo?
Nope, I always thought it could be Tony Romo. It's Tony Romo for the Green Bay Packers.
Oh, so Aaron Rodgers.
That's Aaron Rodgers, yeah. Yeah, I did not have to ask him permission to use this. He posted this publicly. So that's right before, I believe that was 2 years ago, he snapped his clavicle clean in half. So, and the red is painted on, that wasn't actually part of it. Okay, so we got a nice clavicular fracture. Oh boy, got something wrong going on here, don't we? I don't think your humerus is supposed to look like that, and that's definitely not a funny fracture. Right, so that is a non-union fracture of the humerus right now, right? How are they gonna fix that? What are they gonna have to do? Does anyone have any thoughts?
Open them up and pull them apart and put them back together with fixation.
Yeah. Now, if they're lucky, they might not have to open them up. They may actually just be able to pull it And this part mates up with this, but I don't think so because we've got some comminuted pieces out here. So that's probably not going to happen. So I probably will have to do an RF. But one of the first things they're going to have to do, even if they open them up or don't, is they're going to have to grab a hold down here on the elbow and dislocate or distract the arm that way. And so think about this for a second, because this is all fractured and these bones are sliding together. Yeah, Anthony's like, oh God, that sounds painful. Yeah, right? Most of the time when they, even if they're not out with the anesthesia, the minute they start pulling on that, it's done natural anesthesia. You're passing out. Right? And then you wake up because they stop pulling and they're like, okay, now we got to set it. Oh, I'm going to pass out again. Right? So we definitely got a fracture going on there. Here we've got definitely a problem with this humeral head. That's not where it's supposed to be. That humeral head has completely and utterly removed itself from where it's supposed to be. And I think, if I remember correctly, this is a, I want to say, because there's my clavicle. I think this is a rare one, because I think this is a posteriorly dislocated humeral head, if I remember correctly. We have a bigger problem over here. Does anyone see what the problem is over there?
Looks like the head of the humerus is broken now.
Yeah, head of humerus is gone. Yeah, it is not within our standard of procedures or skills of practice or whatever you want to call it for relocating the shoulder. Nope. Does anyone know why you don't want to do that if it's dislocated? Why you want to leave it to somebody other than the fact that you could get sued?
Is it your nerves?
Yeah. Right? Because right in here, like right now, that axillary nerve is being squished in there. So now say I pull this out here and I slide it back up and I'm actually trained on how to do it, I can rip that axillary nerve right off. And, you know, relocating, it's great. I fixed your arm. Now you've lost axillary nerve. Or the axillary nerve will end up getting pinched in here. No bueno. Right? Does anyone know what this is called down here? That is not the way the muscle's supposed to look. That's a biceps rupture, right? That is a distal biceps rupture. Does anyone know what the nickname for this tear is called? Popeye tear, yeah. Right, because it looks like Popeye from, so there's a cartoon when I was growing up called Popeye, and his muscles looked all weird and it looked kind of like this. He constantly walked around with Popeye tear until he ate his spinach. But yeah, so at this point, the distal end of the bicep is torn off and the muscle is now rolled up in here. So in order to fix this, they've got to unroll the bicep and reattach it down there. Pretty common for weightlifters actually to happen. I watched that happen at the gym once when I was at Planet Fitness. The guy was really working and he was straining so bad. I'm like, man, you're going to tear something. You're going to tear something. You're going to tear something. And the next thing I looked over, his left arm, Popeye teared. And I'm like, job security. All right, some other pathologies here. We have shoulder dislocation. Most of the time, again, we talked about this yesterday, dislocation of the shoulder occurs anteriorly. And remember, it's the humeral head movement, right? So that means that my humeral head slides anteriorly. And both of these pictures come from a great book. Go ahead and talk, whoever's talking. I heard somebody pop it on. Oh, I don't have that book here. Dang it. Oh, no, there it is. Oh. Can I get it out this without breaking these computers? So this is not a required textbook for you. This is Stanley Hoppenfeld's, I don't know if I can get it to focus, Spine in the Extremities. I don't know how much this book costs now. Back when I bought it, this was literally like $280 some. I think it's down to like $60 now or something like that. If you can pick this up on digital or used or anything like that, I highly recommend this book. This book was written in 1976, and there has been no new editions of it. Think about how rare that is, right? This book itself has been so useful to me over my years, but what I really love about this book, I can post it, yep. So it's see, Stanley, oh, I got typed there. Stanley Hoppenfeld physical examination, spine and extremities. I'm not saying you have to buy this. The ISBN is 08385785535. I'm not saying you have to buy this, but I love this book because this book has all the special tests in it, and it has most of your range of motion stuff in it. And the one thing I like about this book is these dang pictures. These are all drawings, but he's drawn of patients. And that's where I got both these pictures at. And I don't know, like they just have the best pictures in the entire world. Like this guy just looks like he lives in a trash can because he's Oscar the Grouch. But it's showing an anterior dislocation of the shoulder. This guy here is showing the position of apprehension, which is this here. And this is where you put the arm in 90 degrees of abduction, full external rotation, and full horizontal abduction. And if you push from the posterior to the front, usually most people are going to make that face. Because what you're doing is dislocating the shoulder. But these photos for that book just are fantastic. I don't know. I love the book because I've used it quite frequently in the clinic. But if I have a shoulder dislocation, the most common method of injury is forced shoulder abduction with external rotation. So when I'm out here and I kind of get forced backwards, the humeral head will pop forwards and out of the socket it comes. Here's looking at impingement syndrome, which is an overuse syndrome, where we get a lot of the acromial arch, humeral head, and soft tissue gets swollen. And then you end up with the shoulder that kind of looks like this if they do a soft tissue image on it, where everything's all puffy and swollen. And if it gets that puffy and swollen, obviously, there's no room for movement in there anymore. If I have an overuse syndrome where everything's swollen, how do I resolve it? What is the first thing I have to do?
Rest.
Rest. Yes. Right. So you have a volleyball player that's got overuse syndrome of the shoulder, impingement of the shoulder. You have a pitcher. You have a basketball player. You have a football player. You have a lady that works at a warehouse. The first thing you have to convince them is the only way this is going to get better is if you rest. If you don't rest, it's going to stay inflamed and it's not going to get better. Also, what kind of modality are we going to start using on this? Ice. Yeah, right. We want to chill that all out and get it calmed down. If we don't make it better, if they don't rest, they don't kind of elevate it, they don't compress it, and they don't let it heal, their overuse syndrome will become chronic at that point. And literally then any motion they do of that shoulder will cause that shoulder to flare. And some of you may have a chronic shoulder condition where you do a little bit too much and all of a sudden, man, that shoulder just seems to swell up or get sore really easily. I know my left one used to do that. I'm in luck now because I can't feel it. So I guess that's a good thing to think about. But it's really easy that once you've injured that shoulder, almost like the ankle and the knee, stuff like that, as soon as you injure it, if you injure it again, it doesn't take much to re-injure it. Adhesive capsulitis, which we talked about yesterday, or frozen shoulder, but according again to Dr. Vreskin, there is no frozen shoulder. It is adhesive capsulitis. We do call it frozen shoulder with patients, right? This is where we get inflammation and fibrosis of the shoulder joint capsule. Again, with frozen shoulder, it is typically a capsule problem, which means it is going to present in what type of a pattern? What is it called when the capsule's damaged? Capsular pattern. Good, right? We can do rotator cuff repair. I have two different videos here for you guys in case you're interested in watching them. I have a rotator cuff surgery and a total reverse shoulder or reverse total shoulder. Why do you think they call it a reverse total shoulder? Does anyone know? Has anyone seen anybody or know anybody with a reverse total shoulder? So no one has seen it. Well, so think about this real quick. For a normal shoulder, I have my glenoid cavity, my glenoid fossa, my humeral head, and my humerus. In a reverse total shoulder, they put the ball now in that glenoid fossa, and they almost put like an acetabulum out here on the humerus. So they reverse the shoulder. And what we found is if a patient has to have a total shoulder replacement, these reverse total shoulders are far more efficient than doing like a total hip where you would replace this part and replace that. So they literally just swap it. So they'll go in and they'll ream out that glenoid cavity and they'll put a ball there, just like a humeral head would be, except that's now attached to the scapula. And then they'll come to that surgical neck, they'll cut that surgical neck off of that humerus, and they'll put a cup on that humerus. And now when they move, the humerus is still moving, but they've literally swapped the humeral head and the, yeah, it is weird, right? Man, that's going to mess up my convex concave rule.
Well, I was going to ask, does that mess up any of the muscle or like the arm movements?
It does, for sure. I think my headset just turned off. Yeah, so basically, anything's right. So the humeral head is definitely now on the scapula. It's not a real humeral head anymore, but it's the humeral. It's now the head of the shoulder. And then I think John says the reason why we wouldn't do that on the hip. The only reason we don't do it on the hip is weight bearing. Because think about it, if I did this on the hip, right, every time I'm standing, that hip's going to superiorly dislocate. And for whatever reason, I don't know who the guy was that came up with this reverse total shoulder, but before we were doing total shoulders, it was just a standard one. From the patients that I've seen, because I've seen reverse shoulders and I've seen total shoulders, a TFTSAH, I think is what they're called, total shoulder or hemiarthroplasty or something like that. I've seen them both, and the patients that have the reverse total shoulders come out better. I don't know why. I would say it's going to mess up your arthrokinematics for sure, like Riley asked, because if I cut off my humeral head, right, and I go back here, let me go back real quick, a few slides, right, there's the head of my humerus, there's all my rotator cuff muscles. Yeah, right, so it does weaken the rotator cuff because a lot of times we're going to shave down some of the area where the rotator cuff's attached. So they may be limited in certain rotation motions. Yeah, they typically are going to have lifetime precautions. And with the shoulder, there's not specific precautions like there are with the hip. The one thing that they definitely are not allowed to do is motion out here. So they're not allowed to do abduction with external rotation, which makes sense because that's the position of dislocation, a position of apprehension. And now you've got it replaced. You probably don't want to do that, right? And kind of makes sense. There's not, so for your boards, there's not a specific set of precautions for the shoulder. So it's not like you have no abduction, no internal rotation, nothing like that. There's no precautions for the shoulder, even a standard total shoulder. The precautions are based upon what the doctor says they're not allowed to do. But this, the video, take a chance, take a few minutes and watch. It's actually pretty cool. I think it's only like 6 minutes. The rotator cuff one's a little longer, but the rotator cuff surgery one's actually kind of cool because when you're watching it, it's like the hip one that we saw where you get to see the cotton candy getting shaved off. So with goniometry and manual muscle testing and for doing mobilizations, the open and closed pack positions. Closed pack position for the shoulder is abduction and lateral rotation. So out here, if I'm way out here, I do not want to mobilize the shoulder. If I'm out here and I mobilize the shoulder, what's going to happen? Because this is also the position of dislocation. Yeah, right? So it's kind of funny that that's what's considered closed pack. The other thing is if I'm full adduction and internal rotation, I'm kind of in a modified closed pack. That's not up here. But the other position, and that's usually where they put the patient in when they are injured the shoulder. If you think about it, that's the sling position. So full adduction with internal rotation is an alternative closed pack position, right? So that's in here. But the good news is if I'm in this position, I'm not likely to dislocate it. Full open pack position is about 55 degrees of abduction, about 30 degrees of horizontal adduction, so kind of back here, and I'm just kind of resting out here. That's the open pack position. That is the position I'm going to do what? Open packed is where we
Mobilize.
mobilize. Good. Yeah, you guys getting this? So that's my mobilization position. And honestly, what I think of with my open pack position is, remember I told you I have the patient kind of put their arm around my hip? If I had them put their arm around my hip, that's pretty much open pack position. Right? And again, you can mobilize the shoulder in most other positions as long as they are not in full closed pack or alternate closed pack position. I can mobilize the shoulder if the arm is just laying down by their side too. I can still mobilize it. It's just my best mobilization position is kind of out here. With capsular patterns of the shoulder, they're limited in external rotation, abduction, and internal rotation. But they're usually limited in external, the greatest, abduction, the next, and internal is kind of my least range of motion. So if I've got somebody that's got limits in flexion, that's not usually a capsular pattern, right? So when I have capsular patterns, if I have a capsular pattern and it looks like a capsular pattern, that means I'm going to mobilize. Okay, so I'm going to do joint mobs. What if I have a non-capsular pattern? What am I going to do then?
Look somewhere else.
Okay, look somewhere else. Good, right? I'm going to stretch and strengthen. Yeah.
You beat me to it.
I'm good. I heard you coming in. I said it, so I'll still give you credit. Too bad this is whose line is it anyway, and the points don't matter. Yeah, so I may strengthen the antagonist. I may strengthen the agonist, right? This is going to be one where we do kind of everything else. Now, with both of these, whether I'm doing mobilization or whether I'm doing stretching and strengthening, I can still do modalities with both. Right? I can do hot packs, I can do cold packs, I can do ultrasound, I can do e-stim. Neither the capsular or the non-capsular pattern rules out modalities. Right? So Diane says, I've got some limits in external rotation. That would be a capsular pattern. Sure. And then I'd also test your abduction, see if you're missing a little bit of abduction, and then see if you're missing a little bit of internal rotation. Usually with what I see is most patients are missing a lot of external rotation. When I say a lot, again, we only have about 45 degrees. So it's not like you have, or 90 degrees, I'm sorry, 90 degrees. It's not like you have a ton. But if you're limited in external rotation, a lot of times it's a capsular pattern. So it'd be interesting, right? It'd be interesting if we get to mobilize that if she gains a little bit of external rotation back. So what we do, and we're going to use Diana as a patient here. Diana's got external rotation limits. She's had her eval. The PT's like, yeah, I think this is a capsular pattern. Let's go ahead and mobilize it. We're going to mobilize her, right? We're going to do as much mobilization as we can. And then we're going to have her use that arm again and see if she's got more range. And then we go, oh, look, she's got 5 more degrees of external rotation. Let's mobilize a little bit more. Let's use that new range, right? And we just keep going through until she gets as close to normal range as possible. Most of us are honestly off a few degrees on external or internal rotation, just because we're tight, right? But let's think really quick, and I'm going to take this one step further about mobilizations. If I'm going into external rotation, which is what she's limited in, my anterior capsule is going to shorten. My posterior capsule is going to lengthen as that humeral head rolls forward. right? So that means that if I'm limited going out into external rotation, my posterior capsule is my tight capsule. Typically. Now, does that mean the anterior can't be tight? Sure, the anterior can be tight. But most times it's going to be my posterior capsule back here. And you can
explain that again, because if you're going into external rotation, I was thinking that like which way you would mobilize, but if you're lengthening the anterior part, wouldn't that be the tight part? Since it's
well, the anterior part's staying. If I do the anterior part, here's my anterior capsule, right? The anterior part actually shortens a little bit. So it if I can do this, that could be it too. I could be weak in my anterior capsule. Not that you can strengthen a capsule, right? But it could be really weak. It's just not letting me move. But a lot of times when I do this, my posterior capsule itself is being stretched the whole way around the shoulder. Does that make sense? Because when I go into external rotation, right? So if I go here, if this is the start of my posterior capsule, it's going to be pulled the whole way around my armpit. When I do internal rotation, my anterior capsule is being stretched way around the armpit.
So for this one, when we're doing internal and external, our arm is always in abduction.
Well, in order to think about it, yes. It doesn't necessarily need to be, right? I can do internal external rotation here. I'm trying to use it as just an example to kind of show off the capsule, if that makes sense.
I think I was getting confused because I always think of it as your arm down by your side, but it's not really.
It's not really, yeah. I mean, this is motion, but it makes more sense to kind of visualize it out here. So here's a good rule of thumb. If I have an external rotation problem, so I'm like Diana's an external rotation problem, and I know it's a capsular pattern, my problem is my posterior capsule. If my problem is my posterior capsule, what direction do I need to mobilize?
posterior to anterior?
Posterior to anterior. Good. I need to go anteriorly. Exactly. So I need to move that shoulder that way to stretch that posterior capsule out. If I am more limited in internal rotation and it's still a capsular pattern, not just I'm limited in internal rotation. So we know that I've got external rotation limits, I've got some abduction limits, and I've got some internal rotation limits. Well, that's why I'm trying to give you a rule of thumb here, Amanda. I'm trying to make this as simple as possible. So if I'm limited in ER, posterior capsule is my problem. That's my problem. I'm going to mobilize posteriorly to anteriorly to stretch that posterior capsule. So if the capsule is labeled as posterior, you're going to go the opposite way to stretch it. It's just like a muscle. Does that make sense? So if I were to give you a question and ask you about, say, that the posterior capsule of the elbow is tight, what direction are you going to mobilize it? You just go, oh, it's the posterior capsule. I'm going to go posterior to anterior or do an anterior mobilization. Yeah, there you go. If I know that I have a capsular pattern and my limit is in internal rotation, or I have one of these people that they're limited in external abduction and internal rotation, I'm going to do a posterior anterior mob, then I'm going to flip her over, right? So my anterior capsule is also tight. And I'm going to do an anterior to posterior mob and loosen up the front of the capsule. For most patients, to be 100% honest, if I have a capsular pattern, I'm going to do both mobs. I'm going to do some posterior to anterior, some anterior to posterior. Yep. I'm going to do both. And it doesn't really matter which one I do first. It's kind of the chicken or the egg at that point. It's like, well, maybe I'm doing range of motion and you're laying on your back. Well, then I'm going to start doing anterior to posterior mobs first because you're already in that position.
Hypothetically speaking, not saying that we would do this with patients, but like say if I'm practicing on my husband, would it benefit or hurt him if I'm gonna try doing mobilizations on his?
Nope. Not, okay. I mean, not unless you do a snap mobilization or one of the ones we're not allowed to do.
No thrusting. No.
Yeah. Yeah, I mean, if you want to practice on somebody that's your loving family member at home, I would stick to grades 1 and 2. So that really kind of soft mobilization and then going to that 50%. And then maybe save the 3s and 4s till we're together. If that makes sense. Right? Until I can be there kind of beside you and Dr. Vreskin can be there beside you just so that it saves you. You can't really hurt somebody. I mean, at a 4, I guess technically you could probably hurt somebody. I mean, if you really got aggressive on that end range kind of vibration, but it's even that's not likely. You'd have to put a lot of force to hurt somebody. Yes, Mr. John.
Could you repeat, like, so if we're limited, because we did limited external rotation and then limited internal rotation. I don't know if I missed it, but like for limited abduction.
Okay, so for limited abduction, all right, that's what you're right there with me, John.
Oh, we haven't done it.
We haven't done it yet, yeah. So if I'm limited in abduction, right? So I'm coming up here like this. What capsule would be limiting me this way? Well, the superior is getting shortened. My inferior capsule is getting lengthened. Right? So my inferior capsule is actually getting lengthened. So my inferior capsule is often my tight part for abduction. So if my inferior capsule is my tight part, which way am I going to mobilize them?
Inferior to superior.
There you go. Good. I made you posterior too, Diana. Posterior will actually loosen that up. So when I'm doing these down here, that'll kind of take care of that for me. So this is the case. Now I've got a patient that's both ER, ABD, and IR is limited. So they've got all of them. They are my true capsular patient. Then I'm going to work this and go inferior to superior. Now, there is a rare case, and the book sometimes does say, not your book, but one of the other books, that a patient may be limited in adduction. So that's a patient that comes down and their arm kind of rests out here where they're not coming fully back into the body. If that's the case, you just swap up. And now I'm going to do a superior to inferior mobilization. Because that's this capsule that's tight. That's holding me out like this. Right? So again, good rule of thumb, and this is not, yeah, superior capsule is my tight capsule. So I need to inferiorly mobilize it. Good rule of thumb. Is this a hard rule? Not really. There's still going to be patients. Remember what I said about mobilizations, right? The research out there is kind of, sure. But this is a good rule of thumb if you get a board question that's talking about the patient is limited, has a capsular pattern, presents as a capsular pattern, is limited in external rotation primarily. What I want you to go is, oh, external rotation, posterior capsule, mobilize posterior to anteriorly. I'm trying to give you a way to get through those board questions on this. Does that help make sense? Did I lose anybody yet? Miss Brooke, how you doing? How you doing?
I'm just thinking on when you talk about lengthening versus shortening, that's kind of where we have to look at a lot, right? For knowing if we're going to be going anterior to posterior, posterior to anterior.
Yeah, so let me change my terminology because maybe the lengthening is not helping you. Let's go back to using active and passive insufficiency. Okay, so if I'm going into external rotation, my anterior capsule is going to go active insufficient because it's getting smaller. My posterior capsule is going into passive insufficiency because it's getting longer. It's going, you know, I'm basically taking the back side and yanking it all the way around to the front side. And so when that happens, if I can't go into external rotation, I'm limited. That means that the side that's my antagonist, the one that's resisting my motion, can't lengthen. So it can't stretch out. It can't go into passive insufficiency. It's too tight, right? Its passive insufficiency is way too short. So we need to lengthen that out. So if it's whatever capsule is the tight capsule, whether it's superior, inferior, anterior, posterior, you're going to go the opposite way with the mobilization. So if my capsule that's tight is my superior capsule, I'm going to go from superior to inferior to stretch it out.
Okay.
Does that help?
Yeah, I think I'm just thinking too deep as like looking at the capsule. I don't know. I feel like I just.
We can have another day where we go over this, like in a review session, if that would help. And maybe I can steal somebody to come here and be, I'm able to steal somebody to be a patient from the other group when I'm in lab.
Okay. Yeah.
Or I'll steal Dr. Johnson maybe and have him be the patient for a little bit, just so that you guys can see it. So again, the idea is going back to that. I mean, active insufficiency, passive insufficiency is more dealing with muscles themselves. But if the lengthen and shorten confuses you, try to keep your terminology similar. Is anyone else lost like Brooke? Because if she's looked, somebody else is lost too. Well, think about it. So when I go this way, Truman, you got to think about one thing though. We're starting out here, Truman. Right? Yeah. Okay. Darn, I thought I brought it. Let me see if I can do it with this because it might work. So when I start out there, I'm here, right? My anterior and my posterior capsule are about extra length. Seeing a model, but okay, you understand? Yeah, we can review it. I mean, this is not the last day we're going to talk about this, and when we mobilize, I think it'll help. When we actually get on a patient, I think it will help. But yeah, again, there's nothing saying you can't mobilize your family members if you want to practice it. But again, be very gentle when doing it. Do not be mean to them. But does at least this part down here make sense? If it's capsular, we mobilize. If it's non-capsular, we stretch and strength.
Yes.
Okay. If I can beat that into you, the rest of it we can get over the semester. And again, this is not the limit on this semester because we're going to be talking about this next semester too. Because when I have somebody that's got a stroke, a lot of times they have a very capsular pattern of the shoulder because it's neuro. It's not muscular anymore, it's neuro. So we're going to be back to mobilizing shoulders again when we talk about strokes. And actually mobilizing hips and mobilizing elbows and oh my. All right, let's stop there. It's 5 o'clock. I don't want to take you guys any further here. I've already fried your brain.